you?
Yep, that'd be great. Good evening, everyone, and welcome to the Eastern Pain Association's webinar series, Bringing It All Together, Future Focus 2020. We appreciate everyone jumping on the call with us this afternoon. We are going to give everyone about 1 more minute to allow a few more callers to jump on. So again, thank you for joining us this afternoon and this evening. We will start the webinar and the session in just 1 minute. Again, welcome everyone to the Eastern Pain Association's webinar series, Bringing It All Together, Future Focused 2020. I would like to introduce our program moderator, Dr. Christopher Garibo, for tonight's program.
Thank you, Michelle. And it's a pleasure to be here with my esteemed colleague from the local states. We hope to make this presentation of great value to all the participants, the program directors, as well as all the attendees, in getting to know the programs that they may be applying to and the programs learning from each other with respect to COVID-related training that may be different from how it's been in the past and what pain medicine currently is and how it may change going into the future. We'll be getting a very broad perspective from different parts of the country. I'll be hopefully joined soon with my good colleague, Dr. Mehta, who is president-elect of the Eastern Pain Association and the medical director of pain medicine at Weill Cornell Pain Medicine Center. I am Christopher Garibo, medical director of pain medicine at NYU Langone Health, and I'm the current president of the Eastern Pain Association. So here we have my local colleagues, Dr. Mei Chin from George Washington Pain Medicine Program, Dr. Andrew Ng from Thomas Jefferson University Hospital, which is where I trained and did my pain medicine training, Dr. Thelma Wright from University of Maryland, and Dr. Lynn Cohen from University of Virginia, Dr. Trent Emmerich from University of Pittsburgh, and Dr. Tu V from Penn State Hershey Medical Center. And we are also joined today by our colleagues from Allergan, who invite you to stay after the Meet the Program Director session for a short training course for chronic migraines. Botulinum toxin for the treatment of migraines will be featured at the end of this pain medicine Meet the Program Director session. We divided the hour into 3 separate categories. They are comprised of the pain medicine fellowship application process, the pain medicine training, followed by career planning and pain medicine as a specialty. And I'd like to start off the pain medicine fellowship application process by giving each of my colleagues here about a minute or so, a couple of minutes or so, to introduce their program, the strengths of their program, and why the current attendees should consider their program and rank it highly. And we can start off with Dr. Mei Chin from GW.
Thank you, Christopher. Good evening, everybody. First of all, disclosure, we are a newly accredited pain fellowship program. We got accredited beginning of April, right in the midst of COVID. And so we don't have any fellows, obviously, on board. And hopefully we hope to have fellows to begin next July. Anyway, so the GW Pain Medicine Program is comprised of 3 major medical centers, the GW Medical Center, the VA in Washington, D.C., and the Children's National Hospital. And these 3 sites will be, I would say, central in the training of the pain medicine fellow. They would spend essentially half time in the GW area and half time in the VA and of course, a month in peds pain. There is also a position for somebody who is interested in peds pain to spend more time at children's, like 6 months, and make this more of a peds focused pain fellowship. But anyway, with all the 3 sites, I believe that we have the ability to give the fellow a wide diversity of patient population in terms of training in pain medicine. And being in the nation's capital and close to NIH, anyone who's interested in research, there is opportunities here. We have elective rotations in complementary medicine, addiction medicine, neurology, neurosurgical procedures, if they're interested. And I think there are other things that I can't think off the top of my head. But anyway, it's also a desirable location. So we hope that all these factors are important in terms of people looking into programs as to where they would like to apply. Thanks.
Thank you, Dr. Chen. Dr. Andrew Ng from Thomas Jefferson University Hospital.
Oh yeah, hi, good evening everyone. My name is Andrew Ng. I'm at Thomas Jefferson in Philadelphia. We actually, the new thing for us is we relocated to a newer facility, probably about 10 miles away from the main campus. So it's a newly built office, and the unique part of our practice is we share office together with neurosurgeons, rehab, and also neurology. So that's one of the unique features that we are able to get to know the other departments and work closely together with them. So that's the new thing, and one of the unique features that we're able to have our fellows experience. You know, as we learn more about pain medicine or we go out to practice, we just need to communicate a lot with the surgeons and our other specialties. Otherwise, we do take in 3 candidates and 3 fellows, and we are a pretty close knitted program. We kind of, because all of us spend time in the same area for 365 days or 1 year.
Thank you for that. Dr. Thelma Wright from University of Maryland.
All right, let me unmute the button. Good evening, I'm Dr. Thelma Wright. So I have been the fellowship director here since I believe 2007. So that was pretty much straight after fellowships. I've been doing this for 13 years. We are a multidisciplinary program. We take 3 fellows. We're hoping we can increase our complement to 4. We are one of 2 programs in the area. So the other program is Hopkins. So if you want to be in the Maryland area, it's either us or Hopkins. So we do get a lot of applicants. We are housed mainly in a rehab hospital. However, we also have fellows rotating in our remote locations, which is more private practice. So a fellow who comes to a program will get the academic practice, which is where they are mostly, and they would also rotate in our 2 remote locations. And this is strictly private practice, and we don't have the usual policies and rules that goes along with working in a hospital. Also, we have dedicated time for didactics. So on Monday afternoons, we have a multidisciplinary team meeting where we have 2 pain psychologists, we have the physical therapists, we have the faculty, we have students, we have residents, and of course the fellows. So that's Monday afternoon. So on Monday afternoons, you don't see any patients, you're doing strictly didactics in the multi-D conferences. We also have neurology, PM&R, acupuncture. We have everything under this roof. So most of the fellows will rotate in their different rotations right here. However, the acute pain rotation, which is a month long, where you get a lot of ultrasound guided procedures, is down in the hospital, and you work with the regional team. And a lot of the fellows do like that rotation because they get to do a zillion ultrasound guided procedures. Now, what about advanced procedures? I know every fellow or every prospective fellow who interviews with me is, do you guys do, in the fecal pumps, do you do spinal cord stimulation? Yes, we do. But I always say, you get what you want from a fellowship. I had one fellow who came in saying, I did 6 months of electives and all I want to learn is how to do spinal cord stimulation. And he would give a video to everybody who came through. So he did a lot of trials and of course implants. So if you come in knowing you want to do a particular thing or know something very well, you just end up getting these patients and doing them. So yes, we do spinal cord stimulation. We do intrathecal pumps, and we're also going into peripheral nerve stimulation also. I think that's about it, really.
Thank you, Dr.
Thank
Wright.
you.
Very valuable points. Dr. Lynn Cohen from University of Virginia.
Oh, thank you for having me. I'm Lynn Cohen. So at UVA, we have 6 fellows, and we always take some anesthesia and some non-anesthesia. We actually have 2 separate match lists that allows us to always do that and to ensure that we have kind of a diverse, diverse fellow group. We are most of the time at our main center at UVA in the outpatient clinic where we have the C-arm and clinic, but we also go to a nearby surgery center called Monticello Surgery Center where we do procedures there as well. The fellows also spend some time on the inpatient service. With 6 fellows, it averages out to be 1 in 6 weeks. Where you see consults and also ketamine infusions, and that's also when you do your operative procedures, so all your neuromodulation procedures, which we also do at the Monticello Surgery Center as well. We also have a dedicated didactic time, so Wednesday mornings is dedicated to didactics. We also have sessions with radiology where radiologists will go over imaging with the fellows so they can learn better how to read MRIs or joint x-rays or really whatever they want. It's worked out really well. And so most people like living in Charlottesville. It's a nice place to be.
Thank you, Dr. Cohen. Dr. Trent Emmerich from the University of Pittsburgh.
Hey everyone, thanks for allowing me to be part of this. Happy to be here. So at UPMC we have 9 fellows per year. On paper it seems like a big program with 9 fellows, but the fellows are spread probably around 7 different clinical sites. And these are all with faculty that are both primary boarded and subspecialty boarded in pain. And you'll rotate for 1 or 2 months with each faculty. And so, by the end of the year, the fellows have a very good experience of some clinics which operate more in like a private practice session and have higher volume and maybe more bread and butter cases. And then other clinics which might, specialize in craniofacial pain or cancer pain. And so by the end of the year, the fellows have a very good grasp from a number of different ways to practice, and they feel comfortable, in the job application process because they probably worked at a clinic that's very similar to the type of clinic that they're applying for. So as far as the strengths of the program, I usually tell our fellows during the application or our prospective fellows during the application process that we're well balanced, I think. Clinically, we see about 50,000 clinic visits per year, almost 20,000 unique patients. And so there's plenty of patients, there's plenty of cases to go around. It is a fellowship where you do have to have a car for it. Most of the sites, again, it might sound scary on paper to hear you go to 6 or 7 sites, but most of the sites are within a mile or 2 apart. They're just at a subspecialty hospital. But you do rotate around quite a bit. So the combination, I think, of the clinical, exposure, there's tons of research and pain going on right now, both in our division and, the anesthesiology department. And then the educational side too, I think is the kind of the third prong of what makes us well balanced. Like Dr. Cohen's program as well, we have, a Wednesday morning dedicated lecture weekly that the fellows all attend. We have a lot of sessions, journal clubs, everything else that's required and above and beyond that too. And so I think it's just a well-balanced program. We do also not consider our fellowships as an anesthesia pain fellowship. We kind of pride ourselves, just like Dr. Cohen said as well, about attracting candidates from multi-specialties, and I think it makes a nice mix for our fellows. So thanks again for having me.
Thank you, Dr. Emmerich. And Dr. Tonu V, I believe, from Penn State.
Yes, good evening. Thank you so much for having me today. So again, my name is Tonu Vu. I am the Pain Fellowship Director at Penn State. We are located in Hershey, Pennsylvania. As you know, it's also known as the sweetest place on earth, and it's true. You can actually smell chocolate when you walk downtown here. We have 4 positions, and 1 position is exclusively reserved for PM&R, and the other 3 positions could be, from any candidates. Anesthesia. We have seen an increase in application from emergency room physicians. So we truly believe in a multidisciplinary approach as well. We have 9 faculty members consisting of anesthesiologists, neurologists. We work very closely with our PM&R colleagues, behavioral health specialists, as you know, and also addiction specialists. We, just like other programs, we have a very strong didactic program. We have 100% board passing rate. We also, believe that although a lot of our fellows, they want to focus, it's only 1 year. And it's a lot to learn in that 1 year. So a lot of our fellows want to focus on procedure. However, we also feel that, when we out there, we have to serve as a pain consultant to our colleagues. So we need to be very well versed in opioid management, for example. With the opioid epidemic and also with the pandemic, we, I would say to our advantage, we have a strong telemedicine program, and we just started a virtual opioid stewardship. As you know, physical therapy is now a cover telemedicine service, if you will. So we able to provide a multidisciplinary approach for patients who have issue with opioid. So I think that's something that, one aspect that we, I feel is also important for our fellows to learn as well. So again, thank you for having me this evening.
Thank you, Dr. Vu. So for all the participants, please feel free to use the chat feature to send over questions that I can review. And furthermore, for the pain medicine fellowship application process, my general question to you is that what are the most important qualities and strengths you're looking for in an applicant, and how are you screening that out in the era of COVID and virtual interviews? Anybody want to take a shot at that question?
I'm happy to go ahead. I think there's, as we all know, the Chronic Pain Fellowship is one of the more popular fellowships and one of the more competitive fellowships. And I think something that stands out when I review applications is the amount of scholarly activity and the detail of the applicants or the level of involvement of the applicant in the scholarly activity. At least from my perspective, it doesn't even necessarily have to be in pain, because we all know that as you go through residency, your interests may change. But I think showing that you have the ability to take on scholarly projects in addition to the clinical duties that you're working on really separates yourself from the pack. Obviously, we're not asking every applicant to have their own first author manuscript done, but I think just the fact that a lot of applicants have, a wide variety of scholarly projects, whether it's poster presentations at national conferences or a contribution to a manuscript or a book chapter, I think that helps separate the applicants out.
Besides publications and scholarly work and presentations at local and national meetings, any other important qualities that you're looking for within your applicants?
I think, one of the main things I look at is the letters of recommendation. Having really strong letters of recommendation in terms of, that the applicant was a hard worker and really that they were willing to learn and, were kind of self-motivated learner, that they're reliable, are important qualities.
Yeah.
So for us, this year we made an effort to review every single application. So my associate director, we actually looked through like 250 applications. And again, in addition to the academic projects. We also look for interest. The candidate demonstrates strong interest in pain. And like Lynn said, the letter of recommendation, we learn a lot from the candidate by looking very closely at the application itself. So we don't, have like a cutoff, like, score or anything like that. And we also truly believe, and I'm very encouraged, I see today we have a very diverse panel as well. As you know, women only made up like 25% of interventional pain specialists. So, we looked at the entire application, and I think that's very helpful when we choose a candidate.
I can pipe in also. So we have a pretty rigorous way. So I think this year we had about 350 applications, and we only take 3 people. And my associate director, program director, and another faculty go through each and every one of them. And they have a spreadsheet. And when I see the way they go through, I say, wow, they look at everything. They look at scores, they look at papers, they look at recommendation letters, where they live, and they actually assign scores. And the only scores they don't assign is pretty much, communication, of course, when we talk to them. And I believe interest in being in Baltimore, and I forget what the third one is. And they also look at things like AOA, and so they look at ITE scores, they look at board scores, they look at whether you were AOA, whether you have a master's, whether you have an MBA. They also look at, recommendation letters, personal statement, and they actually, so it's pretty cut and dry, where you can mention a name and they can tell you what score that person got. So we try to be as fair as possible. And I think it's during the interview where it may be a little different because, of course, you're talking to so many different people. We have about four faculty on a panel, and someone may actually resonate better with someone than the other. So that's where the scores may differ a little bit, but there is a rigorous screening process and assignment of scores. And then during the interview, we assign scores to, why they want to come to Baltimore, their professionalism and their communication. And when we're ranking, when we have people who tie, we would actually sometimes go to whether someone sent a thank you letter or not. So if 2 people have 26 points, the one who sent a letter may end up being bumped up from, so it's quite rigorous, but at least it's fair. I know that if anyone comes to me and says, how come this person didn't come? I can tell you why they didn't get ranked high. And it's not willy-nilly. We actually make sure it's quite systematic. And anyone who ends up here deserves to be here, with not because, their father went to school with somebody or whatever. So it's pretty fair.
And would it have to be a letter, or can it be an email, Dr. Wright?
It could be an email. People send cards. So we have a column on the spreadsheet that says, did they send a thank you letter? I don't read all the thank you letters, but at least it says, check, they sent a letter. And so if you don't send a letter and you tied with somebody, you're probably going to go down on the ranking list. And because we have to find a way to determine who moves up and who. So thank you letters counts. It does count.
Thank you. Very helpful. Any other colleagues? Any other points to make?
I certainly agree that scholarly activity is important, as well as board scores, because the board scores are basically, those are your objective findings when you're just reading a piece of paper and you haven't met the person yet. But it might also be helpful if there's something in the application that shows why this applicant is interested in pain and what sort of background has led to this interest in pursuing a pain medicine fellowship. And whether if they did have a diverse background, like they did things other than medicine, that certainly shows some different kind of a candidate, perhaps not someone straight through medical school, but who has had experience elsewhere. So those things actually do factor in terms of the person as a whole. But the objective findings in the beginning are important, as well as the letters of recommendation.
Thank you. So we're getting some comments, and this is something that's shared by many of the applicants that I've spoken with, where they feel that in the era of the virtual interviews, they're having difficulty standing out. How, in addition to what's been mentioned, do you recommend any other ways for an applicant to stand out, especially if they're going to rank that program very highly? Anything that goes above and beyond a follow-up email or a letter?
I think with what Dr. Wright has mentioned is the personal emails or letters. They do express a lot of interest. I mean, when we review all the applications or we go through interviews, almost everyone sounds the same after a while. Everyone is a great candidate. The letters or emails, they do set you apart, or applicants apart. They express how much interest they come, or whether the location of them, because it's very hard for programs to rank people or rank candidates when we don't know if they're really interested in coming to the area. Because programs are all over the countries. It's very hard for us to know that.
Just want to ask Dr. Wright a question. So as far as the letter, are they directed to you directly, Dr. Wright? You know, obviously you could get like hundreds of emails. Or are they to your coordinator?
So for the most part, they send it to me, because at the end, I mean, for this year, I did a PowerPoint presentation to talk about my program. And at the end, I left the email addresses there, and some of them would, you know, find out what the mailing address is. And they really, when they send it to me, they send it to everybody too. So they send emails to everyone who interviewed them. So you normally, and then usually if they only sent it to me, I will send the coordinator, you know, in the Excel spreadsheet, make sure you check them off as sending a letter.
Thank you. So I think yeah, Dr. Cohen, you want to say something?
Just in terms of like in the virtual age and everything, you know, sometimes also we'll get like a personal message from another program director or faculty member at another institution on behalf of the applicant. And if it's, you know, someone you know and they're really vouching for someone, that can make a difference too.
Sure, personal connection. So we're getting some questions where what is the best way of informing our top choice program? I think many applicants do send follow-up emails and follow-up letters, but let's say there are these two programs that I definitely want to go to, and I really want to communicate that to them, that they'll be ranked very highly. What is the best way of informing our top choice program? If it's been mentioned already, that's fine, but is there another way, any other suggestions of signaling that?
I think just emailing and reaching out, but Trent, do you want to go ahead?
Yeah, I mean, I think everyone's comments have been great so far. The only other thing I can think of is during the interview too. If you know going into an interview that it's one of your top choices, even way before it gets to the point of sending a thank you email, you know, there's always two different types of great applicants, right? There's the great applicant where everything looks, you know, perfect. They do great during the interview, but they don't necessarily specify any kind of specific interest to your program. And then there's the applicant where it has all the same great qualities, but maybe mentions or throws out, you know, I can really picture myself and my husband moving out to live here. Or, you know, I can really see myself, I've read about your program the last year online, and I've heard about your program, and I just can't, I've just been excited about this day for the last 3 months, and I'm excited to finally be here. And I would have really liked to do an away rotation, but I couldn't because of COVID. And you can kind of get the sense, and it's easy, I think, to see who's genuine with those types of comments too. But I think you can really, you know, separate yourself too. But again, that would require you to kind of know in advance that that's one of your top choices. And if you're unsure during your interview, you might not be able to kind of put that foot forward at the beginning.
And
I agree with Trent. I'm sorry, because with the virtual interview, you know, we have seen, you know, candidates from like the West Coast, for example. So during the interview, I think it's very important, you know, to express your interest. Why do you want to come to Hershey, Pennsylvania? You know, it's kind of signaled to me. And if you able to make some kind of personal connection for me, because sometimes when we looked at the application, you know, that's something I think about too. If, you know, I'm offering this person a position, well, how high likely, you know, would this person come to the program, especially coming from, you know, such a far away place?
Yeah.
Would you recommend an elective at your program if allowed?
I think certainly, you know, when you audition, it could hurt, but it could also help you. You know, so right now, obviously, we don't really allow, with the pandemic, we don't allow, you know, any electives, outside electives, but certainly I think it could help. Actually, we took a candidate this year who did very well, you know, when he auditioned with us. So I think certainly it could help.
Thank you. So moving on to the next section, pain medicine training.
Could I ask a quick question?
Please, go
So
ahead.
to all the other program directors who've had the opportunity to interview in person, the normal way, compared to this year, the COVID way. Did it make a lot of difference into how you decide, or did it impact and the difficulties of figuring out how you would rank your applicants?
To be honest, I thought the virtual interviews went better than the one-on-one, because, you know, I had the other faculty there interviewing, and at the end of it, when the prospective fellow got off, we would discuss the fellow immediately. We don't get the chance with a one-on-one. Everybody fills out the evaluations and just send it to the program coordinator. So this time we would talk about them immediately, and then, you know, start giving scores immediately. So I think I preferred this way of doing things versus the face-to-face, because I'm not sure it made much of a difference. You know, except of course they don't get the tour and all that, and they got to meet the fellows, because, you know, between 12 and 1 they would meet the fellows. But I actually prefer the virtual, and I'm wondering whether we would offer that option after COVID. You know, you can either do a virtual or come on in if you want to.
Thank you. Moving on to the next section, pain medicine training. What new tools are you using to teach your incoming fellows this year and potentially next year in the era of COVID? How has your training program changed as a result of COVID?
Does anyone want to jump in?
I would think, you know, probably, I'm assuming for most of us, you know, the incorporation of more telemedicine. You know, when we were kind of shut down during the peak, we were doing a lot of telemedicine, and, you know, once we came back up to full force, we're still incorporating telemedicine into the training. We were doing some prior to COVID even, but now kind of just utilizing it more so.
So
more joint, because we did, you know, with Dr. Wright, more joint cross-institutional journal clubs.
I mean, it was a little challenging to incorporate the residents, because, you know, the residents are used to being in the OR. And so I remember the first month that the residents started coming back to rotate with us, which I think was June. You know, we had to sort of get them used to it, because they only used to go into the OR. And but with the fellows, you know, we jumped into doing tele in March. I believe the last day of in-office visits was March 19th, and around March 26th or something, we started doing tele. So the fellows were pretty well trained before they left. The residents are, you know, getting a hang of it, but we haven't done too many. So what we do now is, you know, we will have an in-office, maybe 2 in-office patients, then maybe a tele, so that faculty may see the tele patient, and then the resident or the trainee will see the in-office patient. So we're not doing as much tele anymore, and if there's any tele, the attending will see the patient. I mean, we'll talk to the patient.
Has your case mix changed? Has the type of patient that's presenting to you changed as a result of COVID?
I don't think our patient population has changed. We still see the same patient population, back pain, or majority of our patients are spine patients. With telemedicine, what we have been doing is all the new patients, we do have them come into the office for evaluation, or the follow-ups. We can either do a telemedicine, or if they have trouble, some patients who just do not have access to computers or telephone, we just have them come in the office for follow-up visits, or phone call if it's possible.
I just want to say also that with the, in terms of the training, we very fortunate here in terms of like the time that we had to shut down. Our numbers relatively low, so we're able to reopen relatively quickly. The other thing about the virtual meeting, I find that we have a lot more participants than before. It's a lot easier now, actually, to, you know, like Lynn and Thelma able to do like the joint journal club. I think it's a wonderful idea. I didn't think about that before, but I think there's a lot more opportunities for collaboration with the virtual Zoom meeting, didactics and things like that.
Has your procedural volume dropped as a result of COVID?
So we had to, we had to sort of stagger our patients to start with. So at the beginning, we started with one patient an hour because we had to do the social distancing, the PPE, and making sure that you don't have two patients next to each other in the recovery area. We just went to 2 patients an hour on our procedures, and hopefully we can go back to where we were. So the numbers, of course, have decreased. We used to max out of maybe 15 or 14 a day, but now we're at 11 because we were doing the one an hour, and now we're at, I think, one every 30 or 40 minutes or something. So yes, the numbers are gradually going up, but they went down to 0, and then now we're trying to pick up because of all the social distancing and stuff like that.
Yeah. Any other colleagues?
I think we, as mentioned before, we pretty much back to, before the pre-COVID, at least for now. And so I'm just wondering, the other question, do you actually require COVID testing for patients coming into your facility for procedure?
We do not.
Yes, we do. Oh, sorry. Go ahead, Lynn.
Oh, no, you go ahead, May.
We do. Only because it's a hospital policy for any patients coming into the hospital, be it in the main hospital or the ambulatory surgery center, they do get COVID tested ahead of time. And the test is good for 5 days. So
Is that a state policy or a hospital policy?
it is our hospital policy. I don't know if it's a state policy, but it's our hospital policy. Yeah.
It could be a barrier as well, because we find that, as you know, the testing could be very challenging for some of our patients. So that could, decrease our volume, procedure volume.
Definitely. It's a major hassle in terms of patients because it requires an extra transportation, and some patients can't afford to keep, coming into the hospital to get tested and then come back again for the procedure. It's not done the same day. They have to do it at least 24 hours before the procedure. So
I think it also depends on the type of procedure. If somebody's getting a trigger point injection or some type of a procedure that does not involve sedation, they may not need that COVID test. But if they are getting sedation and the airway may be manipulated as a result, they should get a COVID test. It can also depend on the position of the patient and where the procedure is being performed, on what part of the body. If it's a neck or facial procedure versus a lumbar spine procedure, that can make a difference. Is the patient prone or supine?
I agree.
Just further considerations. What I'd like to convey to the applicants is that I think we're all seeing some degree of drop in the procedural volume, but the extent of teaching can be greater because of the extra time allowed per procedure. So you may get the quality and the sufficient quantity because of some of the measures that are in place. Your training may not be so negatively impacted as a result. So another question I'm going to ask our panelists is that what are the most important skills to learn during fellowship to be a pain medicine consultant? What is the advice you give to your current and future fellows? What do they need to pick up from you and your faculty?
I guess I can jump in. So, when the prospective fellows interview, they're so interested in, the advanced modalities, the spinal cord stimulation and the pumps and all that. And I tell them, what you need to know is how to drive your needle, know the anatomy, know the complications you can get into. So if you know the anatomy and you know what you could do wrong on this patient, you could really do any procedure. I mean, I remember when I got here, I did my fellowship at UVA, and I believe I hadn't done a cervical discogram. I don't think I did one. And, I had a patient who was referred to me for a cervical discogram, but because I was so savvy with a needle, I knew I could crack a book open and go down and act like a super strap. Done this before, but I hadn't done it before. But I knew what I could get, all the complications I could potentially get into. I knew the anatomy, but I knew how to drive a needle. And so, I looked at the book, I looked at a few videos, and I went down and I taught my fellow like I had done a million of them. So I tell fellows, focus on learning how to be technically savvy and knowing your anatomy and the pitfalls of what you can do to a patient, how you could hurt them. And if you're very comfortable with your needle, you can do any block. And you don't have to do 10 or 15 spinal cord stimulators to be able to do them when you get out of here. Just learn how to do your epidurals and your selective nerve root blocks and your facet blocks very well, and everything else will fall in place.
Thank you. Any other colleagues?
I think knowing who to do a procedure on and who not to do a procedure on, you know, and I think as all the programs on here, I mean, are well-rounded programs. And so knowing that, you know, it's not just an injection, you know, it's usually multimodal therapy, and knowing how to treat using multimodal therapy.
Yeah, I agree too. I think learning how to talk to the patient about how opioids are not the right answer, learning how to emphasize physical therapy and having a discussion about multidisciplinary plans. Those are things that are maybe undervalued that all the fellows should learn. Because like everyone else says, a lot of the procedures, you know, that we learn as fellows become outdated to some degree within several years of being out a fellowship. So I agree with what everyone else has said too.
And I think one important thing I want to also stress, you can't stick a needle in every single patient. If a patient says no and they're waffling about a procedure, you probably don't want to insist they get the procedure because something will go wrong. Or so when a patient seems to be hesitant, I just leave them alone. I just say, okay, whenever you're ready, let me know. Because, you know, there are some people who are just so into the injections, and, you know, you end up doing an injection on the wrong patient, and it's, you know, you just go downhill after that. So pick your patients, like Lynn said, you know, make sure you pick the right patient.
I agree with the rest of the panelists. It's such a short period of time. I mean, you know, just 1 year, the fellowship. So a lot of the our fellows coming in, you know, of course, we only at the beginning of the fellowship, you know, August, but the first thing they, you know, they all wanted to do those procedures. And I agree, you know, I think there's so many other things that they should focus on. You know, don't worry about the procedure, you know, it will come. And like Trent said, you know, there's things I'm doing now I did not learn during my fellowship. I had that basic foundation that I could build on. So that's very important.
Yeah, one of the important thing is the patient selection, and the other part is I find it's important to know the pain generator of the patient. If we can never figure out what the pain generator is, we can never treat the patient or manage the problems. And like most fellows, they do want to learn every single thing. I guess the 1 year fellowship is such a short year. The most important thing, I think the take-home thing after that 1 year is whether they can know the basic anatomy and how not to hurt someone, because these injections can be dangerous if it's randomly placed anywhere. It's just basic anatomy and patient selection.
Thank you. I would also add pharmacotherapy, as well as how to behave like a consultant, how to talk to referrers, and come across as a pain medicine consultant as opposed to a technician. Any other comments on this question?
Well, I agree with what everyone had said, because even though there appears to be a emphasis on procedures, and fellows do like, I mean, not that I've had fellows yet, but I know residents who rotate with us do like to do procedures over talking to patients, that this is a pain medicine fellowship and it's not just wielding a needle, which is important, has its place, but to learn how to manage complex pain issues, and be able to develop empathy for your patients as you become a pain physician.
Thank you, Dr. Chen. Have any current or previous fellows obtained musculoskeletal ultrasound certification from the training provided solely from the fellowship? So I'm going to take that as a no. Is there any type of a mentorship program or any type of a link between the alumni, the graduates, and the existing fellows to help guide careers?
So during orientation, I give a PowerPoint presentation on the day of orientation, and I give them a list of all the fellows, at least as far as I can maybe since 2007, if we have their location. So we give them their contact information, addresses, phone number. So if they know they want to go to a certain location like New York or Tennessee, they can reach out to that fellow to see whether there are any, and usually the previous fellows would also email me to say, hey, do you have any fellow who is good, who, you know, I could interview or who you could send my way. So we get that a lot, where previous fellows will contact me, or the current fellows will contact the previous fellows.
I think this is a very important question as far as the timing of, you know, the job interview and, you know, trying to interview for position. Because of the pandemic, we had seen last year contract being retracted, you know, especially from private practices. And as far as this year, I encourage the fellows to start probably looking earlier than later, just that we don't know what's going to happen in the fall.
We also have the past fellows usually will come back and talk to the new, you know, the current fellows about, you know, particularly private practice and setting, you know, just tips and tricks they learn. And we have a Dropbox account where past fellows will put in just whatever information they think will be helpful to current fellows that the current fellows all have access to. So there's a lot of communication between past and current fellows.
I don't have any past fellows yet, but we have a number of residents over the past years who've gone on to do pain fellowships elsewhere, and they maintain contact with us many times, like through ASRA, ASA, and are a good source. And I often send residents to talk to them if they were interested in seeking a pain medicine fellowship path. So they are obviously a very good source of alumni in terms of trying to figure out what's the best way to move with their career.
And then the good thing is, you know, I have the law degree, so I'm able to kind of skim through a contract and say, oh no, don't take this job, you know, because I'm able to look, you know, still sort of read between the lines and say, you really don't want to take this job. And so they're able to, you know, they'll show me a contract and say, what do you think? And I say, well, it depends on what you're looking for. And, you know, I don't charge them, but maybe I'll charge the new people who apply.
That's a good point, Dr. Wright, to come to your program. You can review the contract.
You get free contract review.
I don't have a law degree, but I spent like about 15 years in private practice. So, you know, from that experience, I'm able to, you know, when you look at certain practices, you know, you could help them to, you know, what to look for and what, you know, what to avoid.
Mm-hmm.
That's valuable too. So any other background benefits to your fellowship? What percent of your graduates go into academic pain medicine?
I think for us, it's about 50-50 actually. And I would say this past year we had more, actually this past year was 50-50. So in general, it's a mix.
For us, it's maybe 25, 75, 25 going academic. I think there's just fewer academic jobs around. So even, you know, even fellows, if they know they want to be in a particular area of the country when they graduate, they may, and initially maybe they want an academic job, they may end up taking a private practice to get to that geographic area. But I think, I do think there's probably 2 or 3 fellows every year that take an academic position out of the 9 fellows we have.
I think for us, it's probably 1 fellow in every 3 to 4 years. I mean, the reason why I think is most of the pain applicants or graduate pain fellows, they have interest in doing private practice to begin with. But we don't have any biasness against whoever wants to do a private pain practice. If there's someone who enjoys doing them, yeah, that's for us. And I think now with like what Trent was saying, like most of the people, just limited number of availability for faculty members or in academic institution. As maybe now a lot of academic places are growing, they may take more job. There may be more job opportunities at the university practices.
Any other colleagues?
I think similar to what others have said, 75-25, or it just kind of depends on the year. I don't think we're definitely not at 50-50.
Yeah. I mean, I will get it, some fellows who want to go back to where they came from. So this year we had one fellow who wanted to be in Massachusetts because his fiance was there. So he actually did not get a pain job. He was hoping he can transition into pain. So I think it was one of the Boston Harvard programs. So he's doing OR and hopefully he can do pain. And then the other gentleman went to Rhode Island. I think it was an academic institution, but their private practice arm of their pain. So it was sort of quasi-academic. So it depends on where they want to go and what they get, really.
If all of you can please divide the pain medicine fellowship experience between inpatient and outpatient, what percent of your what of the experience is inpatient and what percent is outpatient? Welcome, Neil.
My apologies to everyone. I'm sorry to interrupt, but welcome, and really excited to hear the last few minutes.
What was the question again?
Yeah, the question is, what percent of the fellowship experience is inpatient and what percent is outpatient?
So as you all know, with the program, we have the annual effectiveness meeting or program evaluation meeting, and we always get feedback from the fellows, and I knew they totally hated the inpatient. I mean, they absolutely hate it because when we get to, inpatient, when we're talking about the different rotations and we get there, they don't like it because, they've done it during residency and they want to go into chronic pain because they want to do outpatient pain. So we were able to whittle it down, still adhering to ACGME requirements. So they do a month of acute pain. So a solid month of acute pain because they have to have their numbers. But they like that rotation because they do the ultrasound and all that, but that's all they get. They do the month of acute pain, no more inpatient services at all. And they used to cover call here, but they don't even do that anymore because we don't have them doing that. So just the 1 month of acute pain, and that's it.
Ours is maybe at UPMC 90% outpatient, 10% inpatient. There's no designated inpatient rotation, and all 12 months are outpatient. But the fellows do take call, weekend call, which is a home call, a pager call where you go in and see patients about 1 weekend a month, and that's during the week. There's a mid-level provider like a nurse practitioner or a physician assistant that covers all the inpatient services. So it's about 1 weekend a month of inpatient responsibilities.
Thank you. Anybody else?
I would say that going forward, the plan is, the way we organized it would be 90% outpatient and 10% inpatient would be acute pain. We have a very busy acute pain service. Palliative care would come under that, and inpatient consults, which occurs all the time. It just depends on whether you get more consults on one day or the other, but the majority is outpatient.
I would agree with that. Our program also is mostly outpatient. So the fellows on call, I think 1 weekend a month, and that's the only time that they would, have any responsibility in the inpatient service.
In our program, we have 1 month for acute pain and palliative care where they spend almost all their time in the inpatient service. The rest is all home call if they do get called, and the other portion where they spend time in the hospitals are consults. Fortunately, we do have a very good acute pain service, so and they have APN to help them out and the residents, so they do a very good job to help us to minimize the inpatient consults for chronic pain.
And ours is, say mostly out, 1 in 6 inpatient consults, and then also we have admissions, so the ketamine admissions or pumps. So if it's a cancer patient who gets really sick, it'll just be in a consultant, the consultant. But if it's, we do some spasticity management as well. So we'll do pump trials for spasticity. So if they're generally healthy, the fellows get good experience with that.
Any other colleagues? I just want to emphasize that the inpatient pain medicine experience can be very valuable to a pain fellow. It will make a more complete consultant out of you. It will give you experience with IV PCA, epidural PCA, acute pain, acute and chronic pain, chronic and acute opioid pharmacotherapy, infusions. It will make you a more complete pain medicine clinician. And I agree that most fellows don't like to do inpatient pain medicine, but it is of great value from an understanding of pain medicine and learning pharmacotherapy and chronic pain pathophysiology and IV and PO analgesics.
I'd like to add that I think it also provides an economic value to the hospital as we try to improve things in terms of patient stay and reduction in opioids. And so we have a real opportunity to shine here and make a value add to the hospital service.
Yeah, absolutely. I think it also incorporates you into a variety of different administrative meetings and pathway meetings within the hospital. So especially for those of you that are interested in academic pain medicine, do try to seek out more inpatient training.
I think in terms of people who are even going into private practice sometimes too, that's sometimes how people build their practice, is sometimes they actually will do consults because that's how they ultimately can generate referrals.
Yeah, so thank you for that input. So as we wrap up here, I'm sorry, I was on mute. I didn't realize I was on mute. As we wrap up here, what are your final parting pieces of advice to current applicants and current trainees as they go through their pain medicine training? What is the best advice you can give them as we wrap up the session? Anyone?
There's a lot to learn in 1 year, and recognize the fact that you're going to learn a lot, but that you'll continue to learn even after fellowship.
It's a great field to be in. And I feel that I'm, such a privilege to be able to practice pain. And after 20 some years, I honestly could say that, I'm very glad that I choose this field. And I think it's definitely worth, pursuing.
I want to emphasize what Lynn just said, that your training is just the beginning, and when you are done, you don't stop learning, because it's lifelong learning. If you want to be a good pain physician and continue to deliver good care, that you should continue to improve and better yourself, and learn things as time goes on. You never stop.
And, I always, residents will come to me, those who were sort of on the fence, they're not sure whether they want to go into pain or regional. And I tell them the beauty about pain is you're more versatile. You can do 50-50, or you can do, a bit of, outpatient medicine, pain medicine, and of course, inpatient pain medicine. You could choose to, focus on, and now we even have pain doctors who are doing the marijuana, the cannabis thing. We can't because we're in academic practice, but I believe that you have more options when you go into pain medicine versus, the OR-based faculty who is in the OR most of the time. But with pain, you can sort of pick and choose how your schedule would look like. You can do a day of acute pain, a couple of days in the floor suite, and maybe, see patients in the outpatient clinic. So you're not, doing the same thing every single day, putting patients on pump and off pump, but you're doing different things during, in a week.
Dr. Emmerich?
I would just add, for those of you guys that are applying maybe this next round in the spring, not to overthink the interview process too much. I know, at least at our program, to get an interview, you kind of meet all the right things that a pain fellow should have on paper. You have the right scores, maybe, you've done the right scholarly activities. And oftentimes the applicants think they have to really wow you and list every scholarly activity you've done. But oftentimes the interviewees or the people who are interviewing actually just want to see if, you know, they're able to carry on a conversation with you and would be able to work with you for a year, and how that interaction goes and how you would interact with patients is kind of an example based on how you're interacting with the person who's interviewing you. So I think it's all about just relaxing during the interview as best you can in that kind of a situation and not overthinking it too much too.
Yeah.
Really.
And I guess sorry. One
Yeah,
more
go ahead.
thing I wanted to add, though, I've had a lot of requests for tours. Can they come in and get a tour? I'm not going to do that because I just don't want to give one applicant an edge over another. So, because if we get to meet you versus the person who couldn't fly from California, so we are not offering any on-site tours at this time.
Well, I'd like to thank our panelists for their input. I believe we all learn from you, and I think we all learn from each other, and I'm sure our all the participants and attendees benefited from this exchange. So truly thank you on behalf of the Eastern Pain Association. We all benefited, and I would like to invite everybody to stay for a session sponsored by Allergan, with respect to interventional pain management of the chronic migraine patient. So please do stay after this program, meet the program director session for a short injection training course that will be the beginning of your pain medicine training. And thank you to everybody, and thank you to all the participants. Neil?
Thank you very much.
Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Okay, can everybody hear me?
Yes.
And can you see the...
Yes, we saw it for a brief second, but we saw the model. There we go.
There we go. Okay, we'll get started so we don't keep everybody. Good evening. My name is Michael Barnhart, and I want to thank the Eastern Pain Association again for having us back. You know, it's been very exciting to support you guys over these last 3 programs. We have learned a lot as well about what is changing in pain medicine, and it sounds very exciting. Tonight, we're just quickly going to review the Botox chronic migraine paradigm for patients 18 years of age and older. A few key points before we get started that I covered last time. The paradigm consists of 31 sites across 7 head and neck muscle areas that are believed to be associated with migraine. Each injection is 5 units of Botox for a total of 155 units. And for the injection, we'll use a 30-gauge half-inch needle. Patients should be retreated every 84 days. Always injecting the whole paradigm that you'll see tonight. And while injecting, you always want to be aware of the angle and depth of the needle, as well, again, that the dose that you give for each of the 31 sites is 5 units. The last thing before we move into the presentation is this is obviously a short presentation. It's top level. There's a lot of injection insights and considerations that we could tell you about. We won't be able to cover them tonight. So just please reach out to your Allergan representative or myself, and we can set up a private training to either come to your office or either do like this virtually, which we're doing now with a lot of departments, residents, fellows, in order to educate people during this crazy time. So we'll start with the anterior injection sites. And the first muscle that we are going to inject is the corrugator muscle. The corrugator muscle attaches at the skin of the eyebrow right above the mid-pupillary point. And it's a triangular shaped muscle that goes down to the nasal frontal bone. The easiest way to localize this muscle on a patient is to place your thumb on the medial aspect of the orbital bone. And you're going to ask the patient to squeeze their eyes or furrow their brow. And when they do that, you're going to visualize and palpate the bulkiest part of the muscle. And generally, it's just about a finger breadth off the midline from the nasal frontal bone, approximately. When you inject this muscle, we use a 1/2 inch needle, 30 gauge, and we inject on a 90-degree angle, and we inject into the most superficial aspect of the muscle, and we give 5 units. There are 2 corrugator injections for a total of 10 units. So once we complete the first one, we'll immediately go over to the bilateral side and complete the second corrugator injection. After that, we'll move on to the Procerus muscle. The base of the Procerus muscle resides directly in between the 2 corrugator muscles. Corrugator injections. So we'll find a midpoint between those 2. And again, we'll inject on a 90-degree angle, superficial, 5 units. And that is the only injection for the Procerus muscle. The third area on the anterior section that we inject for is the Frontalis muscle. For the first injection, which we call the medial injection, we find the first corrugator injection, and we go vertically right above that in the upper 1/3 of the forehead. When we think of the Frontalis muscle, we think about it in thirds. We're always going to inject in the upper 1/3. So again, we find the first corrugator vertically up, upper 1/3 of the forehead, and that'll be our first injection. Our second injection, we go 1 finger breadth lateral from the first injection, and we're also in line with the edge of the cornea, or the lateral limbus of the cornea. These injections are given at a 45-degree angle with the needle facing upward, and we go superficial again, 5 units. And we'll do the second one, and then we'll do the bilateral 2 other Frontalis injections, because we're giving a total of 4, 2 on each side, for a total of 20 units of Botox. And that completes the anterior portion. Secondly, we'll move on to the temporalis muscle. For the temporalis muscle, we're going to give a total of 8 injections, 4 on one side, 4 on the other. In order to localize these injections, we look for 2 locations: the tragus of the ear, and then what we call the helix of the ear, which is approximately right here on the top of the ear. For the first injection, again, we find the tragus, and we go 2 finger breaths vertically right above the tragus for the first injection. So it's right in line with the tragus, 2 finger breaths above. The second injection is 2 finger breaths vertically above the first injection. The third injection, we go back to where we did the second injection, and we go 1 finger breath forward to the face, and then we find a midpoint between the first and second injection. And at this point, we've basically made a triangle. The third injection is given 1 finger breath posterior from the second injection, and that one is in line with the helix of the ear. For all of these injections, we're always going to make sure that we stay within the hairline. And when we inject the needle, we're going on a 45-degree angle, posterior, away from the front of the face. And again, 5 units in each one. So needle 45 degrees, facing backwards towards the head, back of the head, away from the front of the face. 5 units. And then we'll go right to the other side and complete the other 4 temporalis injections. Then we'll move on to the posterior injections. And the first muscle that we'll inject is the occipitalis muscle. We're going to give a total of 6 injections, 3 on one side and 3 on the other. For the first injection, in order to localize it, we want to find the mastoid process, the conical portion right behind the ear. then we're going to look for the inion. The inion is the most posterior portion of the occipital protuberance. The occipital protuberance is laying right here at the bottom of the occipitalis muscle. And we're going to find the inion, which is the most posterior and prominent portion of the occipital protuberance. You'll place your thumb on the mastoid and your pointer finger on the inion, and you'll find a midpoint right between those 2 points. And that'll be your first injection. The second injection will be a diagonal finger breath from the first injection at the 10 o'clock position. And the second injection will be a diagonal finger breath at the 2 o'clock position. All of these will also be on a 45-degree angle with the needle facing upward towards the top of the head, superficial, 5 units. Once you do those 3, you'll repeat the other 3 on the bilateral side using the same localization. The second to last muscle area is the cervical paraspinal muscles. We're going to give a total of 2 injections on each side for a total of 20 units. We're again going to look for the occipital protuberance, and we're going to find the base of it right near the nuchal ridge. We're going to place 2 fingers right at the base of the occipital protuberance, and where my second finger is, we're not going to inject anything below that. So for the first injection, once I have my 2 fingers in place, I'm going to take my top finger away, and where my bottom finger sits, I'm going to find the midline of the spine, and I'm going to go just off the midline of the spine, about a finger breadth, for my first injection. The second injection will be vertically vertically from the first injection, 45-degree angle. So about a diagonal finger breadth on a 45-degree angle vertically. And for these, we're also going to go on a 45-degree angle with the needle facing upward, 5 units in each. The one thing you want to keep in mind with the cervical paraspinals is, again, you don't inject below where your second finger is. And it's also good to have the patient sitting in a neutral position so you don't have a tendency for the needle to go deeper than it needs to go. And then we'll repeat the other 2 cervical paraspinals injections on the bilateral side. Lastly, we'll do the trapezius muscle. This consists of 6 injections, 3 on this side, 3 on the other, for a total of 30 units of Botox. We're going to find two localization areas. We're going to find the necklace line, or the inflection point, and the AC joint. Once you find these 2 areas, for the first injection, you're going to place your thumb on the AC joint, your pointer finger on the necklace line, and you're going to find a midpoint in between those 2 points. All your trapezius muscle injections will be given in the uppermost portion of the trapezius, just posterior to the anterior portion of the muscle. So right where that anterior edge sits, you're going to be just posterior to that in the uppermost portion. The second injection will be a midpoint between the AC joint and the first injection. And the third one will be a midpoint between the first injection and the inflection point, or the necklace line. All of these will be given. This time we're going to go on a horizontal axis, approximately 0 to 10-degree angle, almost like landing a plane, superficial, and give 5 units in each one. And then we'll go right to the other side and complete the other 3 using the same localization technique. And then you have completed all 31 sites over the 7 head and neck muscle areas for 155 units. And that is probably as quick as you will do it once you get used to it. Generally, the procedure takes anywhere from, we've seen it done anywhere from 5 to 15 minutes in an office once a physician or nurse practitioner or PA has been doing it for a while and is comfortable doing it. So at this point, I'll take any questions if anybody has a question. I don't know if what is the reimbursement for this procedure? So that's a great question. Reimbursement, it varies amongst insurances, whether it's Medicaid, commercial, Medicare. We at Allergan are very lucky to have a team of reimbursement business advisors that handle all the reimbursement, coding, prior authorization assistance for your office or for the clinic. So what we recommend is if once you get trained, you meet with your reimbursement person who can look at all your plans and give you an idea, on what your reimbursement rates are and how to help you get Botox approved. So I don't have a direct answer because it can all be different. But it's very, very widely covered. It's very rare that we hear Botox is not covered. With Botox for chronic migraine, there is a step therapy normally with other preventative oral medications, but most of your patients have probably tried that once they get to you, and you will get it approved fairly quickly, and we can help you with that. So I hope that answers your question. I don't have a direct answer though, but we do have a team that can help you. Any other questions in the chat or anybody want to unmute or ask? I don't see anything coming through. I don't see anything coming through. So unless anybody else has anything else to ask, thank you again for the opportunity. We hope this is helpful, and please reach out. There's so much more information about this we can share. We also train in head, neck, and shoulder pain for cervical dystonia and focal spasticity. So if you're seeing those in your practice as well, we're happy to talk to you more about that as well. So thank you very much.
Thank you, Michael. Thank you, everyone, for dialing in.